to this section. We'll be discussing psychiatric disorders in pregnancy and in the puerperium today. I am Dr. Wale Ayegbisi. I'm a consultant obstetrician and gynecologist, and I work with Obafemi Awolowo University Teaching Hospital in Nigeria. Psychiatric disorders is a challenge, especially in the developing world. And it's also a challenge in the tropics but why the challenge is not more in the tropics is because there's usually more support for a pregnant woman in the tropics. So at the end of this lecture, you should be able to understand the significance and incidence of mental health in obstetrics. You should know normal mental health and basic physiological changes in pregnancy, and mental physiological changes. You should be able to know the mental health problems in pregnancy and puerperium. You should know the management of psychiatric disorders in pregnancy and in puerperium. Then you should understand how the drugs work and the dilemma in using drugs in pregnancy and puerperium, especially for patients with psychiatric disorders. Pregnancy does not generally pose an increased risk for severe or psychiatric disorders. However, majority of pregnant women have mild psychiatric disorders. And this is definitely common. A woman that is slim, a woman that initially she's concerned with her shape or with her body, then gets pregnant, then started noticing that her shape becomes abnormal, then she will start having psychological disturbance, psychological worry that her shape is being distorted. Now, apart from the hormonal imbalances, apart from the challenges in eating, challenges at vomiting, and challenges that comes with pregnancy, all these pose risk of psychiatric disorders in pregnancy. But usually it should be mild. You should not need any drug most of the time. However, in some instances, it can be very, very severe. Now, greater than 80% of women with puerperal psychotic disorder have their first ever psychiatric illness in pregnancy. You should note that. Meanwhile, a previous history increases the woman's risk factor for psychiatric disorder in pregnancy and puerperium. Now, a woman that has had a previous history of psychiatric disorder or a woman that has a family history, it poses a challenge in pregnancy. There's high risk that such a woman will come down with puerperal psychosis or any form of psychiatric disorder in pregnancy. Now, the psychosocial stress comes with being a new parent couple, and that is what I was trying to refer to. Coupled with the psychological changes of pregnancy and childbirth, attendant destabilizing factors. There's a new child in the family, and there's a new worry, there's a new care, there's a new challenge for the couple, especially the woman. She becomes worried, she needs support. Okay. Now, pregnancy does not impact significantly on the incidence and presentation of psychiatric disorder. Now, that means that, but it poses unique treatment challenges. Now, you have a patient that has psychiatric disorder in pregnancy or in puerperium, there's no problem. But the main problem is if such a woman's management goes beyond counseling or support, such a woman will have a challenge because of the challenges with drug. There's need to consider psychological alternatives because drug treatment may not be entirely safe for the fetus. Okay. Now, incident of puerperal psychosis, this is the commonest one, and depression can be as high as 15 to 30%. Major depressiveness can be as high as 10%, and moderate can be as high as 3 to 5. Moderate severe depressive illness can be as high as 3 to 5%. And now, there are patients that you have to refer to psychiatrists, especially those that have common problems. They keep asking questions. They get poor sleep. Patient does not eat. Patient stand up at night, doing nothing. Baby is asleep, and they are having challenges in sleeping. Such a patient might need a referral or a tranquilizer. Now, normal changes that you usually see in pregnancy includes, and this can be seen in antenatal, and this includes mixed feeling about being pregnant. Like I've mentioned, you are looking at your body as a woman. A woman looks at and wonder, how do I get this big? How do I get this bloated up? Especially for such a woman that has been slim before. Then challenges of being that's especially for a woman that does not have support. You have unable to cope with challenges of pregnancy. Okay. Now, there's increased emotional liability. They become unstable. They become a little confused of what to do in some instances. Now, the normal or minor depressive symptoms can be seen in first trimester, and that is the period when a woman is trying to adjust to getting pregnant. Then anxiety, fears regarding delivery. What kind of delivery am I going to undertake? Then there's this obsessional thought regarding the safety of the baby, especially at the third trimester. Such a woman is thinking, will this baby be normal? Will this baby be a boy or girl? Will this baby be normal? Will this baby have 2 hands? Will this baby have 2 heads? Will this baby be a fine baby? And all that can be normal in pregnancy. Okay? And in perinatal and postnatal period, there's a period we call pinks, and this happens within 2 days of delivery. There's elevation of mood, there's excitement, there's occasional overactivity, and slight poor sleep. These are still normal, and this can still be seen as normal changes that can happen in Peuperium. Then there's a period we call blues, and this happens within the first 2 weeks of delivery. And this happens to 80% of women. In these challenges, you have patients with poor sleep, lack of sleep. They can't just sleep. They keep looking at the baby. They keep appreciating the baby, but they can't sleep, okay? Baby cries at a slight cry. Even when they have support, they wake up, okay? There's fatigue, there's short temperedness, and there's depression. Now, this depression should not be much because sometimes they look at themselves and look at how they look poorly kept, and they're worried. Now, there could be occasional tearfulness. All these should be mild, and they should resolve spontaneously. And this patient should come back to normal by the 3rd week. Now, the way the challenge is when these symptoms I've mentioned become exaggerated and it becomes dangerous and potentially harmful. There's a danger. Such a woman needs to see specialists first, and such a woman needs to see psychiatric perinatologist first. Now, these are the red flag signs. The red flag signs includes poor appetite. A woman is having poor appetite, not eating, low self-esteem, is thinking, what is happening to me? Will I be able to return to normal self? Will my shape be able to return to normal? Will I be able to wear my old clothes? Will I be able to do what I used to do? Then repeated panic attack, recurrent low mood that is prolonged more than 2 weeks, guilt. Some have guilt, they become hopeless. They feel that so they have been subjected to taking care of child. They cannot go out, especially in patients that do not have support. Some thoughts can be so dangerous and become harmful, and they started having suicidal ideations, poor sleep. They have all this affect their affect and mood. Now, there's need for proper screening of mental health for every woman in pregnancy and in Peuperium. And this, like I said, because mental illnesses in pregnancies could be unpredictable, and this must start in antenatal clinic during booking. And once these risk factors are identified, such a woman is noted, and proper management can be started or can be instituted early in them. Now, prophylactic treatment management strategies instituted that I've mentioned, then detailed problems at an early and at an earlier stage are more easily treated or treatable. Okay, it is the responsibility of all specialists looking after pregnant women to identify these risk factors, and that way it will be easy to manage them. And these screening questions or screening factors, like I said, must start at booking. Okay, and at booking, the questions to ask are simple. These questions should form part of the routine clinical histories. Now, past history of mental illness should be found out. You should find out from a patient, a pregnant woman, that whether she has had any history of schizophrenia, any history of depression in her last delivery, or even when she was not pregnant, has she had any previous history of psychiatric disorders? Have she been seeing a psychiatrist? Is she on any medication? You should ask whether there's been previous admission of psychiatric care as an inpatient. Then family history of mental problems should also be found out. Now, also at booking, you should ask for on a pregnant woman whether they have a need to talk to someone. Do they have something that is affecting them? There have been several occasions that a woman will present to you and they will look dejected, they will look depressed in the clinic. And you ask them, what's the problem? They will not want to open up. Such a woman may lack support at home. Such a woman might have issues with care of herself, and such a woman, that should be found out. Then you should be able to find out, you must find out whether the patient is feeling low or depressed or hopeless. There are instances where you must know that. Then you should also find out, is there anything that is bothering them? Do they lack interest in pleasure or lack interest in doing things? Or you ask such a woman, do they have any feeling that they need to speak with someone? Such should be found out. Now, there are some psychiatric diseases that the first onset is seen in pregnancy. Such a woman does not have any condition earlier, has not had any challenges in the past, but the first incident of psychiatric disorder is noted in pregnancy. Now, we must know that, you must know that umbrella discussion of puerperal depression should be disregarded or discarded. That should not be discussed these days, because there's proper management should be instituted in such a way that etiologies of each case should be identified. And when that is identified, that can be tailored to proper management. Now, you should note that the greater part of new onset psychiatric illness presents in the puerperum. Okay? About 30% of women with major depression during pregnancy have no preceding history. That means that even onset of pregnancy, psychiatric diseases or disorder at the first onset in pregnancy could be as high as 30% among those that have such disorders. Mental illness may develop in pregnancy, irrespective of previous absence of psychiatric disorders. I've mentioned that. Now, the physiological changes in pregnancy with associated unwanted symptoms like paramesis, poor feeding habits, physical changes, coupled with psychosocial issues, poor coping mechanisms, and in some poor family where the support is lacking, such a patient can have onset of psychiatric disorders in pregnancy, especially in the puerperum. Now, management of pregnancy in women with pre-existing psychiatric disorders. Now, ideally, most of such a woman should have a preconception counseling. This is common in the developed countries. It's common in the West, but down in the tropics, it's not, preconception care is not common, and that is a challenge. Most women with psychiatric disorders or pre-existing psychiatric diseases, they should have a preconception care. In this time, patient is properly counseled. There's need to adjust the drugs. There's also need to ask questions whether it is even not appropriate to get pregnant at that time. Now, as soon as the patient have a note to get pregnant, then they go ahead. Now, the issues to be discussed includes further the impact of pregnancy on the condition and the risk of relapse and deterioration should be discussed. The long-term capacity of successful parenthood should also be considered and discussed with the woman and the couple generally. Safety of medication should also be discussed. That means, like I've mentioned earlier, there might be need to tailor or reduce the drug that could be seen to be harmful in a patient that has been a psychiatric disorder before. And that is vis-a-vis exposure of fetus to such drugs that could be teratogenic. Then access to treatment and care. If you are pregnant, will you be able to see a psychiatrist or an obstetrician as early as possible? Then early involvement in pregnancy of women with either ongoing diseases or a past history of mental illness should also be assessed. Now, we should discuss case specifics, especially for a patient that has had a known psychiatric disorder. The first that is common among all the pregnant women, especially what in puerperal conditions or in the puerperum, is depression. Depression comes with a lot of mood challenges. There's persistent feeling of sadness, there's loss of interest and enjoyment with reduced energy, leading to increased fatigability and diminished activity. This comes usually in a patient that has poor support, really, and a patient that in the past has had labile mode, or a patient that has had previous history of psychiatric illness, or a patient that has family history. It is commoner in them. Now, depression is diagnosed at least 1 in 10 women throughout their lifetime. No evidence suggests that pregnancy reduces relapse or improves the mood of women with active depression. So previous history of depression not related to pregnancy carries between 1 to 3 risk in of a postpartum depressive illness. Now, in cases with previous depression in postpartum period, in some of these women, the recurrence could be as high as 50%. So such a patient must be monitored by skilled obstetrician and with the involvement of a psychiatrist. Okay, other conditions or other things that must be put into consideration in depression includes depression adversely affects the diet, attendance at the antenatal clinic, and such a patient can have self-harm, domestic violence. Okay, depression impacts negatively on bonding with the newborn because some of them depression leads to a situation whereby the woman has this feeling of not wanting to care for the baby. In fact, it could be as bad as trying to harm the baby, and it could even affect themselves. Now, management should be tailored towards psychological treatments. However, if this is not possible, behavioral therapy, counseling, interpersonal psychotherapy could be instituted. If all these are not useful, there must be need to commence medication immediately. Tricyclic antidepressant drugs is commonly used. It has no teratogenic effect, so this is safe. Now, can be used in pregnancy and in Peuperium, and during breastfeeding. Now, there are possibilities that selective serotonin reuptake inhibitor SSRIs increase the risk of congenital abnormalities. Okay? Now, such risk, this can lead to preterm labor and can lead to low birth weight. So, such should be monitored in a patient that has depression in pregnancy or in Peuperium. Okay? In pregnancy, most especially because the patient could have a preterm labor. Now, minimization of the dose of antidepressant drugs is very, very important in late third trimester. And this is why you do not want the effect to be seen in the baby. And this could prevent anticholinergic, serotonergic, and extrapyramidal side effects in the newborn. Now, electroconvulsive therapy is not absolutely contraindicated. If it is needed, this must be given. Now, the other condition that should be considered or that can be considered includes schizophrenia. Schizophrenia is a chronic mental illness that is characterized by hallucination, delusions, and disorganized behavior. It affects how the individual thinks, feels, or behaves. Now, preconception care is very important in a patient with previous history of schizophrenia or developed schizophrenia in pregnancy, and may seriously limit parenting skills because bonding is usually affected. Now, after delivery, woman and a baby may benefit from admission under the management of perinatal mental health consultant. Okay? Extra social support and surveillance will usually be necessary, but this may be due to poorly tolerated by the affected individuals. Because sometimes they see themselves as not wanting to be associated with people, and when you are trying to give support, in some instances can be seen as harm. They see themselves as, does it mean that I cannot care for myself? So, and they seem to feel that they know more than the others. They do not want the baby to be taken away, and this can have a serious challenge on the fetus and the baby and the woman. Now, it's usually a multifactorial challenge, especially it's usually an inheritance disorder, and offsprings of such a parent are at risk of developing schizophrenia in future. Management. Common drugs include haloperidol and chlorpromazine. Those are very common in the tropics, and those are drugs that are commonly used. Other drugs that can be used are fluopentazole and fluphenazine. They are also very commonly used. And it's good because they do not have any convincing teratogenic side effects on the fetus. Now, the risk of disease relapse are considered to be greater than any theoretical risk of exposure of fetus to the teratogenicity, especially if you have a drug and you are considering that these drugs can be at a danger to the fetus. You should think first of a relapse in such a patient that can badly damage the care of the woman. So if there is a need to balance a relapse and drug administration, it is important to know that the risk of relapse is very high and should be considered in management. Now, careful reduction in the dose of the drugs can be done at the third trimester. Encourage breastfeeding to promote bonding with the woman is also important. Bipolar affective disorder is one other clinical psychiatric disorder that must be considered, and it is usually referred to as manic depression. Preconception counseling is very imperative, and majority of as high as 50% of women with bipolar illness have postpartum relapse. Preventive therapy must be commenced immediately after delivery, and this includes as soon as baby is delivered, without waiting for such a patient to develop such a condition. Once the history has been noted, treatment is a combination of mood stabilizing drugs, lithium, carbamazepine, and sodium vaporate is considered. Antidepressants and neuroleptics, these are drugs that can be used. But it must be noted that lithium carries a risk of cardiac defects in the first trimester. So it may be better to actually commence lithium if it is necessary after delivery. Okay? And patient may be, and it should also be, you should note that lithium is contraindicated in breastfeeding, and it can be delayed or put the patient on bottle feed, on the baby on bottle feeding. Now, it may cause hypothyroidism, fetal hypothyroidism, and polyadrenals and diabetes insipidus if used in third trimester. Now, other drugs that should be considered, but they are also teratogenic, is carbamazepine and vaporate. They are also teratogenic, and there is a risk of relapse if medications are stopped abruptly before or just after conception. So there must be a way to balance the treatment and continuing the pregnancy. And that is why preconception care is very, very important. Fetal risk of continued medication may be accepted, okay, if the maternal risk of stopping treatment will be grievous. So fetal risk of continuing the medication can be considered, or a termination of pregnancy if it's deemed necessary. However, the risk of relapse is more grievous. Pregnancy can be continued and medication still instituted, and that will be considered much later. The other condition that is very common in pregnancy and Peuperium, and it's a psychiatric disorder, is anxiety disorders. Anxiety disorders is just a mood swing, and this is usually referred to, associated with striking features of mental and physical symptoms of anxiety. Patients keep thinking, will this baby be normal? Would I be able to return to my normal self? Will I be able to take care of this child? Will this baby have normal head? Will this baby have normal hands? And patient becomes increasingly affected with these thoughts, and they start having challenges. The whole process of womanhood can trigger anxiety disorders, especially in a woman with previous history. Okay? Now, psychosocial and behavioral therapy may help to avoid or reduce drug treatment in some of them. These patients keep seeing a psychologist, and they keep treating or keep counseling such a patient. Now, benzodiazepine is a useful drug in them. This helps them to relax and allow them to sleep. But this can be associated, if used in the first trimester, it can be associated with cleft lip or cleft palate. Now, it is important to know that babies or patients who have high doses in pregnancy experience withdrawal effects of benzodiazepine, especially if the drug is used at the third trimester. Now, puerperal psychosis. This could affect as high as 1 in 1,000 women in Peuperium. 1 in 1,000 women is significant, and this is a challenge, and this must be noted. Onset is characteristically sudden, and it's commonly a patient that does not have any risk in the past, and most commonly present at the 5th day postpartum. At that time, patient or the woman is getting to understand that she's pregnant, she has delivered, she needs care, she needs to take care of herself, she needs to take care of the womb of the baby, she needs to take care of the home, and such a patient needs support. Risk factors include previous history of puerperal psychosis, previous history of depressive illness, family history of bipolar disorders, and affective psychosis. Okay? Now, common symptoms in such a patient includes restlessness, confusion, insomnia, that's poor sleep. You should know that anxiety disorders can lead to puerperal psychosis to that. Then delusions, hallucinations, refusal of feeds. Patient does not want to eat anything, she's worried. Then depressive symptoms such as self-worthlessness, hopelessness. And it could be as bad as having suicidal ideations. These are the common presenters. Management of puerperal psychosis, it's multidisciplinary. And this involved a psychiatrist and an obstetrician. Now, vis-a-vis also included in the management is a psychologist. Patients should be admitted immediately. Admission should be done in a way to prevent separation from the baby, because this could affect bonding. Drugs that can be used, especially if there's associated mania, is lithium, also chlorpromazine and haloperidol, neuroleptics, they also can be used. Electroconvulsive therapy can be considered if it is necessary, but this may be required because this is what? It can be started immediately, because most of the antidepressant drugs will not take effect immediately, and that can be delayed to the 6 weeks before the effect can be felt. Antidepressants can be used up to 6 months after delivery. Recovery is usually occurs within 4 to 6 weeks after medication has started, or even after electroconvulsive therapy is used. Now, you must know that 50% risk of recurrence is seen in puerperal psychosis. That means a patient that has had it in the past can have it again. And this is common in a patient that within the last child or last delivery or last pregnancy and the current pregnancy is within 2 years. And recurrence is very, very high. That means that a prophylactic treatment is not uncommon, and that can be instituted immediately within 24 hours of delivery. Postpartum depression. At least 10 to 15% of women will have some form of depression in the first year of delivery. And the reasons are things I've highlighted. There's becoming womanhood, becoming the challenge of becoming a parenthood, having a support, having to care for another child in the family, having to live with the expectation of being a mother, and having to still care for herself. Such a patient could come down with postpartum depression. And this is common in the first year of delivery. Now, but gradual onset usually happens around 6 weeks postpartum. Yeah, spontaneous recovery within 3 to 6 months without treatment can happen. It can be spontaneous. However, like I've noted in the past, 1 in 10 will remain depressed in the year. Now, risk factors for postpartum depression: previous history of psychiatric illness, depression during pregnancy, especially for women that do not have support during pregnancy. Every woman needs support in pregnancy. And once you have a client or a woman that does not have support, always coming to the antenatal clinic depressed, dejected, no husband support, no care at home, or sometimes some of them are even having physical abuse, such a patient needs further care, and that should be considered for them. Postpartum depression can be considered or can be seen in them. Now, adverse obstetric factors such as cesarean section, fetal loss, and fetal demise, and neonatal loss can also lead to postpartum depression. Okay. Now, poor support and deprivation is important also to be noted. That can lead to postpartum depression, as I've highlighted earlier. Poor relationship and abuse, and adverse life events such as loss of loved ones is a risk factor for postpartum depression. Now, symptoms include lack of appetite, I've mentioned that, lack or loss of interest, reduced libido, uninterested in enjoyment, downward mood variations, and worse symptoms in the mornings. Now, lack of appetite, I've mentioned that as a symptoms. Other symptoms in them include lack of concentration, they cannot concentrate, they have occasional tearfulness, feeling of guilt and failure, anxiety disorders, thought of harm to themselves, and it can be as bad as suicidal ideations in which they try to harm themselves or kill themselves. Now, treatment options for postpartum depression includes, you should know that the earlier the onset of depression, the more severe it comes. But for clients or patients that have previous history, it is better to have a prophylactic management within 24 hours of delivery. However, for patient that is having the first onset, the earlier it begins, then the more severe it's likely going to be. Now, psychosocial factors should be considered, and these include counseling, proper support, normal formal counseling in which there's a group already instituted in community or previous patient that has had such episode can come in line and help to counsel such a client. Then interpersonal psychotherapy is also important cognitive behavioral therapy. And this includes using counseling, using a psychiatrist, in which such a patient is being counseled thoroughly, and this must have been started in antenatal care. And if it's a new onset, this can be started immediately after delivery. And if this is not going to be helpful, then pharmacotherapy can be started immediately. Tricyclic antidepressants, selective serotonin reuptake inhibitors can also be used. Now, it must be noted that depression and progesterone treatment must be discouraged. Now, because some have believed that in the past that it is sudden withdrawal of progesterone or estrogen after delivery that leads to depression in such a woman or in such women, it must be discouraged, because especially if instituting progesterone treatment is going to affect the mood, or it's going to affect starting the proper treatment, before we know it, or before you know it, the damage will have been done. The patient would have come down with further depression, and management will become more difficult. Now, adverse sequelae can be seen in postnatal depressive illness, and this can be immediate or late. Okay, the immediate conditions include physical morbidity, the patient tried to harm herself, damage to the body, physical harm. Now, prolonged psychiatry morbidity can also be seen. Then it becomes continuous. Then poor bonding, poor bonding is damage of social attachment to the infant and impair emotional development in the infant. The infant does not even know the mother does not breastfeed the child. The woman has this feeling of guilt. The woman has this feeling of trying to kill the fetus and even kill herself. Now, late complications or late sequelae includes psychosocial or cognitive effects of the child. Such a child comes down with such a problem, comes down with a psychosocial factor, comes down with depression, withdrawn to self. Then there could be psychiatric morbidity in the child, or future mental problems in the child can be inherited. The increased rate of divorce can also be seen in them. Now, there are some other little conditions that I want us to consider, and this is very important, and this must have been taught in drug use in pregnancy, but we are going to consider that drugs used in pregnancy and breastfeeding as regards psychiatric disorders, and this can be seen in form of teratogenicity, and can also be seen in form of antenatal side effects and other conditions. Now, in teratogenicity, this is common with mood stabilizers. Lithium is associated with cardiac defects, so it should be avoided, especially at the first trimester. Valproate is strongly associated with neural tube defect. This also should be avoided at the first trimester. Antidepressants, paroxetine and SSRI, that's selective serotonin reuptake inhibitor, is linked with fetal cardiac defect. That should also be avoided. Benzodiazepam is also cause an increased risk in facial cleft, especially cleft palate and cleft lips. That should be avoided. Tricyclic antidepressant is seen in it's a condition. It's a drug that can be used as routinely as you can, because it is not usually associated with teratogenic side effects. Other antenatal side effects of drug use in psychiatric disorders in pregnancy includes this is rarely used now, monoamine oxidase inhibitors. It has vasoconstrictive effect, and this can impair placenta's function, especially blood supply to the fetus, and this can be affected and can be avoided during pregnancy, and especially during pregnancy. Now, chronic use of antipsychotic drugs may cause glucose intolerance, and that's why the drugs can be carefully tailored to reduction during the third trimester and especially at delivery. Now, neonatal effects of the drugs used in psychiatry includes the lithium can cause fetal and neonatal hypothyroidism. I've mentioned that earlier. SSRIs, that is serotonin selective reuptake inhibitors, have been linked with persistent pulmonary hypertension in the fetus. Okay. Now, benzodiazepams used later in pregnancy, especially in the third pregnancy, can lead to something that is called a syndrome called floppy baby syndrome. And this is characterized by depressed respiratory effort at birth, hypotonicity, and poor feeding. And that is why such drugs must not be given at the third trimester, or can be tailored with a reduction towards delivery. Now, TCAs and SSRs may lead to a neonatal abstinence syndrome, and that includes irritable neonate becomes irritable, jittery, slow to feed, restless, with poor sleep and occasional convulsions. Okay, now breastfeeding. Now, drug use in breastfeeding, carbamazepine and valproate they are safe. These can be used in pregnancy. It should be noted that TCAs, that's tricyclic antidepressants, and typical antipsychotics are secreted in small quantities in breast milk, though. Therefore, majority are not contraindicated in breastfeeding. SSRIs are found in higher quantities, but those with short half-lives, such as sertralin, may be considered. Lithium could cause neonatal toxicity. It is therefore contraindicated in breastfeeding because it could cause fetal toxicity, it could cause neonatal toxicity among them. Now, finally, previous personal or family history of psychiatric illness is important. Women with a previous mental illness should be counseled of possibility of recurrence in pregnancy. Collaboration management, that is multidisciplinary, especially involving a psychologist, a psychiatrist, and obstetrician, is recommended. Now, postpartum screening for depression is also essential, especially those that have had previous history. Drug prescription should be done with caution to avoid teratogenicity, and breastfeeding, though should be done under guidance, it really needs to be avoided. So, at the end of the day, you must understand that a careful high index of suspicion is very imperative in psychiatric disorders in pregnancy and Peuperium. Patients that have previous history have high risk of recurrence. So there's need to balance management, drug administration, and fetal risk and relapse together, and that is why a multidisciplinary management is very, very important. Thank you very much.